really what it comes down to is how do we, protect patients who are at their most vulnerable, either medically or just in their life stage of, hey, I'm in the hospital. No one wants to be in the hospital. And it's our job to make sure that they come out healthier than when they came in.
Hey everybody, welcome to this week's episode of Let's Talk Solutions, Candid Conversations with Healthcare Leaders. I'm John Amos.
And I'm Amy Fritzer. And this week we're going to be discussing infection prevention and how the COVID-19 pandemic has impacted how hospitals and healthcare facilities fight to reduce hospital-acquired infections, or HAIs, as well as infection prevention's role in keeping patients, staff, and visitors safe.
And today we're joined by two very special guests, Erva Trotter, EVS Director at the UCHealth University of Colorado Hospital, and Luke Draper, Infection Prevention Specialist for UCHealth. Welcome, Erva and Luke. We really appreciate both of you guys being here and bringing your expertise on this important topic. Let's get started. All right, so Erva and Luke, thank you so much for joining us. I'd like to start just by opening the floor to both of you just to kind of explain some of your background and your experience with infection prevention. And Luke, we can go ahead and start with you.
Great. Thank you guys so much. I really appreciate the chance to come talk with you guys and talk a little bit about infection prevention, which is great. So my name is Luke. I've been an infection preventionist at UCHealth for about 2.5 years. Before that, I've got a background in microbiology and public health. And in between that, I also did some work at a vaccine company. So I've been able to kind of hit a couple different, sectors related to healthcare and biomedical sciences and that sort of thing. I did my public health degree in hospital and molecular epidemiology, which is about as focused as a master's degree toward infection prevention as you can get, which was great. And, was able to start working in infection prevention, and then COVID hit. And now I've kind of been through the rodeo, right, of COVID and everything. And it's been quite an experience, but it's also been really rewarding. So happy to be here.
Awesome.
So Luke, what did you say you got your degree in again?
So my degrees, I've got a bachelor's in microbiology and then a master's of public health in hospital and molecular epidemiology.
Man, I can barely spell that, let alone pronounce it. That's impressive.
That's
It's
awesome.
taken me about 2 years to not trip over it every single time. So I'm like finally to the point where it's not, which is good.
It's like this long on your diploma.
Mm-hmm. Yeah, it's a big one.
That's awesome. Cool. Erva, how about you? What's your background in infection prevention? I know you've been in EVS for a while, so why don't you dive into that?
Yeah, well, I just want to say, first off, starting with gratitude, thank you guys for having me on. My name is Erva Trotter, EVS Director here at UCHealth. I've been with UCHealth now about 2.5 years. I started with HHS in December of 2008, so time is definitely flying by. Coming up this December will be 13 years. Worked with environmental service within many organizations such as HCA, Tenet, CHS, and now UCHealth across some of the states of, Texas, Mississippi, Florida, and Colorado for HHS. So time is flying when you're having fun.
That's awesome. That's awesome.
Yeah, so obviously you guys are right in the thick of things, especially with COVID, and we all know that hospital-acquired infections, or HAIs, as they're called in the industry, are a major safety concern. When you say HAIs, most people go, I don't really know what that means. What exactly does that mean?
Yeah, so HAI it's kind of an umbrella term. It's something that the CDC uses to define something that a patient didn't come in with, and then they get to the hospital, they pick up some variety of infection. And there's a whole bunch of subcategories that part of my job and part of the team that I work in's job, we look at cases, we determine if they meet the criteria for those different types of HAIs, and then we put in interventions based on that to see what we can prevent. So there's a couple main types of HAIs. In no particular order, you've got SSI, which is a surgical site infection. You've got CAUTI, which is catheter-associated urinary tract infection. You've got CLABSI, which is central line-associated bloodstream infection. And then you've got C. diff, which is a spore-forming bacteria that causes diarrhea.
Where would that come from?
So C. diff is, like I said, it's spore-forming, which means it creates this hard coat around the bacterium, and it makes it really, really, really hard to kill. And so maybe you have a patient who picked up C. diff. It does exist in the community, but maybe they picked it up, came into the hospital, they're having diarrhea. And the C. diff is spread in that diarrhea, and then it gets into the environment, it gets onto healthcare worker hands, and can potentially spread from person to person. So that's one of the metrics that I do a lot of work in, and I can tell you it's hard to prevent. C. diff is really good at not getting killed and getting to the next person.
So in terms of monitoring and providing like hospital surveillance of that, what does that look like within the hospital setting?
So most hospitals use what's called an EMR, which is electronic medical record. And so at our hospital, we have Epic, which is one of the big ones. And it's a software that we use that has all the information in the hospital is in that. And so a patient, right, is going to have their medical record. It's going to have all of their tests. It's going to have all of their different like labs, notes that providers put in about them, the monitoring that's done. So you can get the full picture of a patient in that medical record. And the big useful component is we can then use all of those labs that get aggregated into reports. So, every C. diff test goes on to a report that says, here's all the C. diff tests. And then part of my job is going in, reviewing those, kind of determining what is going to happen with that case. Or let's say someone has a bloodstream infection. Epic is going to tell us, hey, this patient had a blood culture. Take a look, see if it's eclampsia. And then it'll feed us all of these cases to go look in. So it's a really, really powerful tool. And we have a whole swarm of people whose whole job is to improve and work with Epic to make it, serve our needs and serve the needs of like frontline providers and all that stuff. So it's really powerful and a great way for us to monitor everything that goes on in the hospital.
So then switching gears, Erva, obviously you oversee the EVS department for UCHealth and working, I would imagine, hand in hand with, Luke's team and the infection prevention team. And how does EVS play a role in preventing the spread of HAIs or containing them, or, are there protocols that you guys follow? Are there certain cleaning procedures that you guys utilize?
Yeah, so just partnering with infection prevention. I know Luke's team, every morning we get generated emails of patients in the hospital that may have C. diff, that may have CRE, or any other known, diagnosis where housekeeping can play a part in doing certain cleaning practices and standards within those rooms. So, just having that generated email, being able to present that to our staff on the front end prior to them starting their shift helps them to be better prepared. Our team needs to know what type of isolation rooms are out there, what chemical to use, the dwell time, being able to speak to it. And they're just more confident going into patient rooms, being able to treat, different surfaces. And it makes everyone feel at ease, from staff to patients as well.
So I'm wondering, obviously COVID is still very prominent, and, we've had, I don't know what number wave we're on right now, but we've had several different waves of it in different, states across the country. But in terms of, what it's like to operate under the conditions that COVID creates within the hospital, how does that impact kind of your approach to HAIs? Obviously, COVID is an isolation room. Does that impact like how many isolation rooms are available for patients that may have an HAI, or what is it like fighting HAIs and reducing those in this kind of environment?
I feel like at this point we've kind of reached at least on my team, we've reached an equilibrium, right? Where we've been doing all of our COVID stuff for so long that it's just part of our daily routine. And obviously that's different for frontline providers. Like when you guys, I know last season you talked with Vince and Bill, right, about the PTSD from COVID and the burnout and just how hard it is for people to, see COVID patients every day and kind of go through this. So that obviously makes it difficult, right? If people are really tired, they maybe would forget to do hand hygiene, or, hey, I don't know if I have time to give the maximum care. I kind of need to do what I can to get to each patient, which makes it tough. But around isolation rooms, we did a lot of retrofitting with our facilities team to say, hey, let's provide as many negative air pressure rooms as possible, because, that was early in the pandemic and there was still kind of discussion going back and forth of, is this a droplet spread? Is this aerosol generated spread? And so we needed to get as many isolation rooms as possible. And so there's there's been so much work done by so many different people, which is, I think, on one thing, it's cool to see, a hospital system work the way it's intended to, where we have so many different people doing so many different things, and everyone is out here killing it at their job and, working at the top of scope. And so that's been cool, but it definitely it's been difficult. It's a lot of work. It's kind of been I had people say a lot like, oh, this is the Olympics for you now for just 2 straight years.
Yeah.
Right? Yeah. Or, I joke, before this, nobody had any idea what my job was. I'd always have to try to explain what is an infection preventionist, what is epidemiology. And now everybody knows both of those, which is, it's different.
Yeah. And from an EVS perspective, there were many changes from the beginning, just taking COVID as an example where, only clinicians were allowed to enter rooms. Then all of a sudden, housekeeping was able to now go in because we've gotten new standards from the CDC that, hey, we're able to help out. We're able to go in. We're able to clean those rooms. It got to a point, where I think with COVID, the average length of stay was around 8 days. And then you can't go with a housekeeper not entering a patient's room for 8 days. And now that, we have the proper PPE, Luke's team helping educate our staff on proper donning and doffing. And hey, it's okay. If you have your proper N95 mask and your PPE, you will be safe. So we owe it to those patients that were in there during that time that, hey, you'll still see your housekeeper, because we're in a time now where you're going to always have COVID patients. There will be those units where we're kind of working through it.
Yeah. Are there tools that, like, Erva, you and your team use specifically to, test for those for HAIs in patient rooms? Or are there specific procedures that you use, or maybe a separate machine that you can use that helps to clean patient rooms or clean ancillary areas, or, clinical areas where bacteria or infection, might be at a higher level?
So currently we use ATP testing, and ATP stands for adenosine triphosphate. It's measuring the gross soil on surfaces within patient rooms. This is something we typically start with in orientation with education with our staff. We'll have them grab the ATP monitor. They'll be able to swab door handles, the mouse that they're using, even their cell phones in orientation, letting them know that when you're cleaning patient rooms, there's contact items such as overbed tables, bed rails, door handles, toilet handles that'll be swabbed in the rooms to ensure they're at a safe level. This will help control HAIs within an environmental service standpoint, so we're not spreading germs to other patients. As team members are cleaning, they'll notice that there's things they just can't see. So I think, using the ATP monitor is a second line of defense to help sure that we're not spreading germs to patients that may come in the hospital. So
I know that in addition to ATP testing, there's other, I think, tools that, I've heard just around in the industry being used, whether it's electrostatic sprayers or something like that. Are there any other tools that you're using that assist in kind of infection prevention efforts?
Yes. Currently, we use our Clorox T360 machine. Okay. This is a electrostatic shock that it's a quaternary disinfectant it's a negative shock into a positive environment. Anybody knows that when you have negative and positive, that's the only way you can get things to kind of stick on. But we use this within our waiting areas and high traffic areas to ensure that surfaces are safe for patients. While staff is cleaning, I always think to myself that no one's perfect. You may not wipe anything, you may get distracted. And just knowing that you have a second line of defense where someone's coming through, spraying waiting areas nightly, high traffic areas, that'll just ensure that surfaces are safe.
Yeah. And I know we're obviously shooting for true cleanliness, actual disinfection, but in terms of also just the reassurance that you can give staff and patients, does that, is there something you're doing to let staff know that you're using this, that you're doing this extra measure, or let patients know? How does that impact kind of perception and then just the reassurance that, hey, we're working and healing in a safe environment?
Yeah. So within our waiting areas today, we have robust rounding of obviously police techs, but there's signage to say, hey, this area has been disinfected. Patients today walking in a hospital in this climate are expecting a sterile environment. So when you see rounding by police techs, wiping things down, disinfecting, we've even gone to the point now where you'll see, furniture being labeled, hey, this has been sanitized. In the past, this is something that wasn't there. You just always assume that, hey, someone cleaned it, but now people want to, see the words written on the furniture. And if it's been used, you'll kind of flip the sign over to say, hey, the seat's dirty, and someone will move on to the next area. But having that reassurance that signage is there, someone's rounding, letting them know what process has been taking place is definitely helpful. People that come in the hospital, I'm reminded as we, visit patients, managers are rounding within patient areas, just assuring them that, the room is being disinfected. You will have services completed for the day. I'm always reminded where, a patient came in, they're saying, hey, my sibling was, had surgery about 2 years ago. I know this is my first time here. They had an HAI with a total knee. I didn't actually want services because I didn't really want, someone to come into my room to minimize that. But I asked for you to kind of come up here and talk to me. So just as a manager, going and explaining why we're wiping contact items, why it's helpful to visit patient rooms, because nurses are in and out. I want to make sure I'm disinfecting that light switch or I'm wiping handles, because so many visitors come in and out, and knowing that, we can play our part in disinfecting those high touch areas. The patient was safe. They were actually glad I came by just to talk about our services and why we were needed. And no better time now than having housekeeping services.
Yeah, no kidding.
No, that's great. Erva, you mentioned police techs. Can you explain what those are and their role in infection prevention?
Yeah, so you think of the word police techs, or you have someone that's cleaning, but there's a police tech who actually floats around the hospital, and their whole role is to maintain an area. So at night, areas are cleaned from top to bottom, they're detailed, but a police tech, may not have that time in a facility that sees, 300 patients a day in an ED lobby, or 5,000 patients a day within our outpatient area. So their job is to maintain the environment from a stocking standpoint to a disinfection standpoint. If someone's leaving a waiting area, to be able to keep it straightened up from a furniture, picking up debris, cleaning glass, cleaning high touch items, and disinfecting. But they're just to be out there to be visible. Something as simple as a spill, they're there to respond quickly, because it's high traffic. It's the entrance door of the hospital, or a waiting area that's extremely busy throughout the day. But there's someone just there constantly monitoring, rounding around the clock.
I mean, it sounds like you have quite a robust program, and probably some pretty robust policies and procedures that you're following there, and which kind of naturally goes into the thought. And Luke, I would imagine this is more for you being the infection guy, but I would think that the recommendation would be, or the hope would be, that most hospital systems, larger facilities, even smaller facilities, would have some kind of an infection prevention plan or policy in place, maybe even a team that manages it, a team such as yours. So if they don't, I mean, obviously, I think the last year has shown that it's probably more important than ever, right? Just a renewed focus on it. So if you're putting together a program, an infection prevention program, what are some of the components, or maybe the most important components that should, and like the teams or the folks, the team leaders that should be involved?
Yeah, we have what's called our infection control plan, right? And so it has a variety of different things in it. We have the different types of isolations that we use. That's one of the infection prevention bread and butter, right? And now it's something everyone is more familiar with, right? Of aerosol transmission, droplet transmission. There's also a lot of what we call fomites, which is a physical object that can transfer a bacteria or a virus to the next patient. So we want to make sure that we have plans in place to monitor what's going on in those, that cleaning is done correctly, that our surveillance for the HAIs is done right. There's plenty of organisms that we do surveillance for that don't actually cause HAIs, like tuberculosis, or we have Acinetobacter or Serratia. These are organisms that can cause serious infections in patients. And even if they're not classified by CDC as an HAI, we still want to make sure that we know what's going on with them. So our infection prevention plan really covers, the bases of surveillance, definitions, rounding, all of this stuff. Like there's a lot of different things. So another piece that we use is what's called tracer methodology, which is something that was created by the Joint Commission, which is our hospital accreditation board. And so what we do on a tracer is we will go out with a set group of questions and survey that. And so we'll look at the unit and say, are you doing this? Are you not doing this? So some examples are going to be, are you storing clean and dirty things together or separately? Do you have items that are labeled with the correct expiration date? Do you have linen that's covered and put away? And so we can take all these questions that, by themselves are kind of a one-off little thing and combine that into how well is this unit reaching up to our infection prevention expectations, and then also above that, our regulatory standards. And so you can take all those questions, you can aggregate them into a report of, hey, we're at 80% compliance. And this gives us a really good way to track where units are at and how we're going to fare during surveys or accreditation events. It's really what it comes down to is how do we, protect patients who are at their most vulnerable, either medically or just in their life stage of, hey, I'm in the hospital. No one wants to be in the hospital. And it's our job to make sure that they come out healthier than when they came in.
Yeah. I'm kind of curious too, in terms of, you have this infection control plan that you have. And, I think it's clear that a successful, execution of that plan requires collaboration between every department and every team at the hospital. What does it look like to partner with each department? Obviously, you're partnering with EVS, with Erva there, but then also nursing and then other departments. How do you kind of build that collaboration and really have like a culture between, from everybody at the hospital that this is something we're proactively doing every day, and it's not just EVS responsibility, it's not just infection prevention's responsibility, it's all of our responsibility to make sure we're fighting this. How do you kind of take something that's a formal policy and plan and get that through to, hey, this is something we're doing every day?
Yeah, what you said of, it's everybody's issue. That's actually part of our about a year or so ago, our team went through and made it like a team motto or, whatever you want to call it. And one of those pieces was we make infection prevention everyone's business. And there's some formal and informal ways we do that. Formal is we have what's called the Infection Control Committee, which is a every other month committee that meets, and we go over the HAIs, we go over departmental issues, and it has people from all across the whole hospital. So we have lab, we've got facilities, we've got food and nutrition, we've got radiology, we've got nursing, we've got frontline providers. So it's really, we have that like official, everybody is involved. And the infection control plan actually goes through that as, is being reviewed. We look at our goals that we set for each year. We look at that. And so we really want to make sure that there's an active role that all these departments are playing officially. Unofficially, infection prevention, I think, functions kind of in a consulting role, right? Where I'm not giving direct patient care, but so a patient isn't really my customer as much as the nurse or a doctor or department serving them is coming to me with questions. They're coming to me with, hey, can you clarify this? Can you walk me through this process? And so we really try to, my medical director told me about the 3 A's of consulting, right? Which is being affable, able, and available. And so we really want to make sure that we are someone who people want to go to and say, hey, we're comfortable asking this. They might feel it's a dumb question, but when it's something that's medical, it's never really a dumb question because anything that they get wrong can be a big problem. So we want to make sure people are comfortable coming to us. And we want to make sure that we partner with facilities to say, hey, like with the air handler stuff that I was talking about earlier of creating negative pressure, we wanted to make sure that they're able to do it before we ask. And then that they're able to monitor that and make sure that it's an effective, like, hey, we're not going to break all of the hospital air systems by doing this. So it's, it's building relationships. And I think recognizing that we're here to serve people who are giving care, or we're here to serve people who are like the EVS team, even who's, cleaning rooms. And so I'm not the one going in and cleaning rooms, but I want to make sure that they're comfortable and safe and prepared to go in and clean those effectively.
Yeah. Hervé, do you have any thoughts on how your team has specifically collaborated with other departments?
Yeah, one thing Luke and I team currently does is our collaborative rounds. So we have biweekly collaborative rounds with nursing, and a IP representative is tagging along as well. So we always think of who cleans what. You know, a lot of time you have a regulatory agency coming, it's last minute. And you're like, hey, I'm not responsible for that. And I think we just have clear lines on who's doing what because we're rounding biweekly. We're looking at things on that can be improved. Talking with our team members, they're understanding dwell times of chemicals on how we can improve the unit. So I feel like just that open line of communication, week in and week out, definitely, plays a part.
And I would imagine a huge part of all this, the whole policy and procedures and program and all that is just ongoing education. I mean, you'd have to be collaborative on that too, right? Across all the different departments throughout the facility, whether it's clinical or non-clinical or so. I mean, Luke, does your team kind of manage that as well? Or Hervé, does your team kind of manage that? Or do you kind of work together on that? And how often do you guys, is it when you guys meet, every other month in your committees, do you guys talk about, hey, let's focus on this issue this time with the whole hospital? Or how do you kind of approach that?
I think one thing that COVID has really highlighted is how difficult it is to change policies and practices, right? So that's one thing we've dealt with a lot is, hey, when we ran out of our normal cleaning wipes in, March, April, May of last year, okay, now we're switching to bleach everywhere. So now we have to educate everyone on how to use raw bleach, how to, mix it safely and how to use it because it has a different dwell time than bleach in a wipe. So there really is, there's just a constant need to be on top of our education. And it's very important. And we are fortunate that we share education duties with a lot of different groups. So EVS does a lot of their own education. We do a lot of education. There are nurse educators whose entire job is to, educate nurses and make sure that they're able to speak that language really well. So our team we do sit kind of in the inner circle of education, and we do want to make sure that we're providing it correctly. But we're fortunate to be able to partner with other people who also share that responsibility.
I know you touched on this earlier, Hervé, but is there anything that you coach your team on how to communicate to patients, help them feel safe? And then if a patient has a concern, how your team kind of addresses that?
Yeah. So, our housekeeper that goes in the room is going to see the patient the most. First, we want to identify if the patient is there or not and explain those services that are in the room. Knowing that we use 5 rags, there's a proper protocol that you'll clean the bathroom last and the room first, letting the patient know what the rags are used for within the specific zones within the room. And just kind of talking through your cleaning process to ensure that there's assurances there that, hey, I won't be mixing or I won't be double dipping my rags, while I'm in the room, because patients are in the bed and they're watching. They want to, hear those sounds that the toilet's flushing, that the sink's running, that you're flickering the lights, that they smell the smell of clean is even a trigger that's in the room. But just kind of talking through the process. And that communication, I think, is huge because patients, they don't know what you're doing. Why are you wiping that? That all kind of plays a part in the education process. Our staff is also, they alert us if someone's not in the room. You'll have a sorry I miss you card that's left there, and a patient thinking like, wow, did the housekeeper skip my room? And they'll leave that card and they'll alert their manager and say, hey, Mr. or Mrs. Jones was out of the room. You should go by and see them and let them know that I did come by and recognize that what the tent cart was actually on the table and that they were satisfied with the services. And since the housekeeper wasn't there to explain the services, the manager can kind of go through and reassure that those services were completed. I can assure you that, while you were getting an x-ray or down for surgery, that we didn't skip your room. I think that's huge because if you miss that moment with the patient, that can mean everything during their stay.
Cool. Well, yeah, I think the education of both, staff is really important. And also just communicating to patients is also really important. But I kind of want to switch gears and dive into kind of the specific partnership IP and EVS has, and how that kind of fleshes itself out in kind of the daily cleaning protocols and things that you do and your team does, Erva.
Yeah, so a part of the cleaning protocols is when a team member gets to the floor, they're able to round their unit to identify the type of patients that they have. They're looking at signage. If there's reverse isolation, we obviously want to clean those rooms first to make sure that that patient's not compromised. We'll also clean our patients who are not in isolation. We'll take care of those to provide our services. And then we're letting our staff know to clean our isolation rooms last to ensure that we're not spreading germs on the floors.
In terms of with COVID and how those protocols have developed, obviously, and kind of evolved since the beginning of COVID. Luke, how has your team been involved in kind of tracking that, seeing what works, providing guidance maybe on how they can implement some other best practices? How has that kind of been over the last 18 plus months?
Yeah, so isolation precautions, if you want to kind of get down into the nitty gritty, it's based on transmission-based precautions. So what we do is we look at all the research that's been done in the field and say, how does this organism transmit from one to the next? Because something like flu, right, that's a droplet transmission is going to be totally different from like Pseudomonas, which is going to get on a surface, it might get in a drain and gets to the next patient. So you have to understand what type of precautions a patient is on to really understand what type of cleaning they have to do. So COVID, in particular was, I think the biggest thing at the beginning was droplet versus airborne. But we also ran into stuff like, hey, do I need to wear a hairnet because people were concerned that COVID would get in your hair? Or do I need to change hospital scrubs because they were concerned that it was going to get in the cloth of the clothing and get to the next patient? So that's the biggest challenge of having a novel organism that comes out, is we don't have this wealth of information and wealth of data as to how to combat and clean it. And so we have to kind of say, all right, let's ratchet this up as far as we can. And we need to make sure that we're safe first and then kind of work back from there. So fortunately, coronaviruses are not particularly hardy, as compared to like C. diff. So we don't have to use bleach. But then when we ran out of cleaner that would kill it, we did have to use bleach. And so there's kind of this back and forth between what do we think is going to kill the organism? What do we know is going to kill the organism? What do we actually have on hand? And fortunately, there's, the transmission-based precautions gives us a framework to start with, and then we can adjust based on the needs for that specific situation.
So Luke, obviously the last year has been pretty crazy for you guys and having a novel coronavirus. So when you were going through your training and your education in your multiple degrees, did you ever train for something like that? Did you guys ever discuss, hey, we might have some new organisms come across, and how would we handle that?
I'd say yes and no. So did I expect that we're going to have like a once in a 100 year outbreak 6 months into my career? No. But, one thing that's, I think, great about public health, and one of the reasons why it's being recognized a lot in hospitals and being used a lot in hospitals, is the modeling and like statistical ability that our field has to kind of say, hey, here's maybe what's going to happen. And so if you look at like major respiratory outbreaks that have happened in the last 40 years, round numbers, there's been about one every 10 years, whether it's flu or SARS. We've seen them with a somewhat cyclical pattern. Obviously, we can't predict like, hey, okay, 2030, there's going to be another one. But, we're not going to be surprised when there's another, big respiratory outbreak. So I think people in public health maybe weren't surprised that something was going to happen, but I don't think any of us really, knew about the scale that we were going to hit. I've got a very specific memory about, I think it was probably late February of 2020. I got called into a meeting with a group of providers, and they were like, hey, do we need to be worried about this? And this is when COVID was just kind of blowing up in China. It hadn't hit the US at all. And I remember talking to them and saying, hey, we have seen this type of thing before with bird flu and swine flu and SARS. So this isn't like totally crazy. It's not here yet. It might be, we'll kind of have to see what it looks like. There's obviously different levels of population density. There's different levels of food practices that do play a role into how viruses move inside countries. But I very specifically remember being kind of like, yeah, we'll see what happens, and then fast forward 2 months later, all of the alarms are going off. We're out of products. Everyone's, losing their minds. It was kind of like, oh boy, this is not what we expected at all.
You became the most popular guy in the room.
Fortunately, I think we were very lucky to have a really deep pool of experience to draw on with our medical directors. And so we really had some really, really great people working to try to figure out, okay, what do we do tomorrow? Because we know what's going on today and we don't know what's going on tomorrow. So I don't know. I think
being proactive versus reactive type of approach.
Yeah, definitely. So I was surprised as much as anybody else. But, fortunately we did, you do go into things like transmission precautions and how do you prepare a hospital to get a huge influx of patients. So I think our hospital has been very fortunate and very well led to be able to, we didn't hit that situation that people did in New York where they were running out of beds and running out of ventilators. There's a lot of things that play into it, but I think I'm very happy with and very pleased with how our hospital has handled it.
And Erva, you've been around for a long time. I mean, you've been a director for 13 years. I mean, did you ever anticipate this, or when you first found out, you were just like, uh-oh, what do we do now type of thing?
Yeah, when it first happened, you almost didn't believe it. You're like, this isn't really much. I'm sure this will go away. It's a hot topic that'll last for maybe a month or two. But it's still here today. We're looking at over a year and a half where you just didn't expect something like this. But I will tell you, housekeeping is definitely important nowadays. Where everyone said no, they now say yes. Please come in my area. Can you disinfect? We'll give you whatever time you need. It's a culture of yes now.
I am curious in terms of how this changes not only just like standard procedures and protocols that you have, how COVID has impacted that, and then also just contingency plans and preparation. Like, what's the impact COVID's going to have even after it's, hopefully gone? What's that kind of impact going to be, do you guys think, within the hospital specifically?
I think COVID has in some ways been there, there's some silver linings. There have been some good that's come out of it. Our hospital stood up some incident command centers, which really gave those folks involved experience in saying, hey, here's what we do. We're going to set up this command center. We're going to answer questions. We're going to get stuff done. And now being able to look back on that and say, hey, here's some things that we learned that worked. Here's some things that we learned that didn't work. And it's really given us, kind of the ultimate testing ground to say, do we know how to respond to this? Can we flex our system to its breaking point and then come back stronger?
I think the good from an environmental service standpoint that came out of this is, things that are the second line of defense. We talked about ATP. We talked about Clorox T360. There are some facilities that use the UV lighting. We have our BioQuell machine that's a hydrogen peroxide spray. That's within a lot of our terminal cleans where facilities were on the fence at some point in spending money. I think now that's more so available because they know that it's creating a cleaner environment for our patients.
Yeah. Is there any worry from either of you guys in terms of, human nature drifting back to status quo, and how do you hold on to some of the silver linings, like you said, Luke, and how do you keep those going forward and not let it kind of drift back? Hopefully one day, COVID's gone and we're past it, but yet how do you keep, moving forward with some of the things we've learned and not let us drift back to maybe some bad habits?
I think that's absolutely a potential. I think human nature is to have a short memory, and fortunately policies and things that are written don't have to have a memory. It's just set in stone. So I think taking the opportunity we have to say, hey, here's what we do for, maybe it's travel screening, or, maybe next respiratory season, we have people who get screened for symptoms instead of just letting people got to run willy-nilly in a hospital during flu season. That, people maybe will be more used to that. It kind of reminds me of the visitor restrictions that we have that in place. So like during flu season in past years, we would have visitor restrictions on some of our heavily immunocompromised units, like bone marrow transplant or solid organ transplant. And having those visitor restrictions, is to really protect the patients who are there. And so while, a couple years from now, people may forget about that, if we can put in policies in place that say, hey, we're going to do this for everybody during flu season, something like that. Or, hey, we're going to have temperature screening or symptom screening for anyone coming into the hospital. I think we do have the opportunity to learn from this and really improve our practices in kind of those minor ways, it doesn't have to be everyone wears a mask all the time. That'll go away at some point. But I do think we have the opportunity to learn and move from there.
Yeah. I guess it kind of mirrors, obviously when 9/11 happened, that changed airport security forever, right? And so I think maybe there'll be a similar effect, in the hospital infection prevention thought. Too. Yeah.
I was just going to say that.
I am curious though, bringing up like visitor restrictions and just, when you think about patient care and, the impact that having a loved one visit can have on healing and recovery, right? Like, how do you balance staying true to the infection prevention measures you need to have while also accommodating some of those maybe emotional needs that patients may have? How does that work exactly?
One of the big tasks that we're given as infection preventionists is to balance the risk of an infection or risk of exposure versus risk of, whatever thing you're putting in place. So visitor restrictions have been a tough thing to work with this year. I mean, even just recently, we've changed ours to walk our restrictions forward a little bit, make them a bit more restrictive because we're seeing higher rates of COVID in the community. I've heard stories of patients who said, hey, I came in on the day that you changed the restrictions, and if I have known, I would have gone to this other place. And that's, that's tough to hear. It's really hard to hear the impact that it has on people, because I think we can't downplay like you said, the emotional effect that it can have seeing your loved ones or getting that family support during potentially the hardest time of this patient's life. So, so it's on us to balance, okay, if we have people coming in who might have COVID and they're giving COVID to maybe the patient that they're coming to see, or giving it to some person they pass in the hallway, like that's a risk that we have to balance. And so we do our best to say, hey, maybe for these patients, you get one patient or you get one visitor a day for 1 hour, or for these patients, you get 2 visitors a day for 2 hours. And so we kind of we try to set up categories of, an end of life situation is going to be different from a person who came in for a broken leg, which is going to be different from, a mom coming in to have her baby. So we just try to put in place clear policies so that our frontline staff are able to rely on that and look back and say, I really understand that this is tough for you to hear. I really understand that, you want to have your whole family here, but just out of an abundance of safety and wanting to protect you and the other people in the hospital, we're going to limit you to 1 visitor a day or 2 visitors.
Yeah. Erva, is that something that your team is aware of and that you're actually coaching them? Hey, visitors, they're not getting as many visitors. That's a need that obviously we can't fill completely, but we can kind of be that emotional kind of connection for some patients that are here. Is that something you talk to your team about?
Yes, we have that conversation all the time because, when visitor restrictions hit, we kind of play our part in going in the room, putting a smile on the patient's face. We're the only ones that, or one of the few that comes in for something that's not, touching the patient, moving the patient, poking the patient, but we can go in there to have a conversation while we're in there completing our job. And I think that's huge. just to be able to put a smile on someone's face, ask them how they're doing. Especially, you get to know the patient if you've cleaned their room several days in a row. You get to know them by name. They know you by name. They're saying, "Hi, Erva, good to see you again. Glad you're here." And that's huge. That's huge in building that relationship, especially when their family can't make it, or they're talking to them through an iPad or just over the phone. But just like you build a relationship with your nurse, you're also doing that with the housekeeping staff as well.
Yeah, it sounds like you both are either the GOAT or the GOAT. So you're either the favorite person, or you're the, or in your case, Luke, that balance can't be easy, especially when we talk about human nature and, like you said, vulnerability and patients, being by themselves. And that certainly inhibits their healing as well. And so I think you both have been in a very tough position. I would think now that it's been so long that there's probably more of a better understanding from, families and things like that. I mean, last summer when my mother was in the hospital, she was at end of life. So we were able to go in and be there. But had she not been, because in the room, like 2 rooms down from her, was someone who was a COVID patient, and their family was not allowed in. And I specifically remember, I don't know if it was a spouse or a brother or how the relation was to the patient, but was talking to the staff about, well, why can't I go in? Why can't my family come in and see her? And, I was kind of within earshot, and they knew the situation with my mom. So I always wondered, well, maybe that's why the staff didn't say, well, because she's dying. And so, it was at that point they let us in. But I mean, I totally believe that it's a real thing. And that had to be really tough to deal with and manage.
Yeah, I think one of the really important kind of transitions or mindsets that we have to have as infection preventionists, or really any kind of healthcare provider, is to see patients as not just a number, not just their medical record number or 56-year-old male with heart disease. Like there's a whole person behind there, and there's a whole family that cares about them. And I think, it's obviously something that we know about, but COVID has really brought that to the front. And it makes it tough, makes it really hard to have those conversations. And so we just have to come in with a sense of understanding and try to be compassionate and really say, hey, I understand. And I want to explain to you why this is, for safety of either your loved one or someone else's loved one.
Yeah. Luke, I'm curious if you've seen, there was a report that came out, I guess it was a press release by the Society for Healthcare Epidemiology in America, SHEA, that it looks like there's been increases in HAIs in 2020 from 2019. Did you see that report?
Yes, I'm very familiar with those. And I think there's going to be a lot of research that comes out in the next couple of years as to what was behind that. I think we have a lot of anecdotal reasons, of staff are busier, or you have people who there was using a lot more antibiotics. So antibiotic resistant infections cropped up more, or you have people who were ventilated for a lot more. That's one that I don't think we need any research for, to know, hey, if we have all these ventilated patients who are not doing well, there's another subset of HAI called VAE, which is ventilator associated event. And we saw a definite upcropping in those because you have way more people using a ventilator. So I think that's a really complex issue. It's one that with C. diff specifically, I've been digging into for 1.5 years, and I'm still digging. So, there's healthcare is complex, it's busy, it's messy. And as much as we don't want it to be those things, and as much as that's kind of our job to make things clean and simple, it's messy. And COVID made it a little messier. And I think we, are now in the position of saying, hey, how can we, next time we have flu season, or next time we have a staffing crisis, like how do we make sure that our hand hygiene and our cleaning and our other basic infection prevention stuff doesn't get compromised?
Yeah, that's great.
If there anything that, kind of the key takeaways that you guys would say to, administrator or someone that would be listening would be, what would be the most important thing to remember when it comes to, HAIs or infection prevention?
Yeah, I think just, working with IP, being transparent. If there's, like Luke said earlier, no question's a dumb question when it relates to healthcare. But if there's something that as an EVS leader that you want to recommend as a second line of defense, whether it's ATP, Clorox T360, UV lighting, I say you should bring it to your administrator or leader's attention, but bring the facts behind it. What are the reasons why we should have it? How can this improve your numbers with HAI, especially with patients? 1 in 5 come in hospitals that can contract an HAI. So when you think about the reason why behind it, I think just asking those questions, partnering, sitting down during your infection prevention committee meetings, and just hash it out. I think that's really going to be what's best.
So my ending plugs are going to be 1, wash your hands. 2, if you're in the hospital and you see somebody not washing their hands, tell them to wash their hands. I think it, really as a patient, I think that's important to advocate for, help patients feel empowered to advocate for themselves and say, hey, I didn't see you wash your hands before you're coming in to access my line. Can you wash your hands, please? So I think that's one plug. Second plug is I think there is a lot of value in infection prevention. There's a lot of value in the abilities that we have with data and the abilities we have to, with all the products to make strides in preventing infections. We always want to shoot for 0 infections. We always want to shoot for, the SIR, which is standardized infection ratio of 0, which is, hey, we did not have any infections. And obviously that's a very lofty goal. Some people might say not achievable, but that's what we want to shoot for. And I think COVID has really highlighted the value that infection prevention brings, the strength that a good infection prevention program can have, and can really say, hey, we can prevent infections, and we don't have to be at the mercy of bacterial evolution, right? We don't have to be at the mercy of these things that we can't see. We can make changes in behavior and cleaning and really, really make a difference in people's lives.
That's awesome.
Yeah, sounds
awesome.
Awesome.
Luke, it's been awesome to have you on. Erva, I know we've talked several times over the last 18 plus months, and it's been great to have you on as well. And just appreciate both of you guys' insight and just all the work that you guys are doing out there on the front lines. I know I get to stay kind of tucked in an office and I'm not out there, but you guys are out there fighting it every day, and I really appreciate it.
I echo.
Well, thanks for having me on.
Thank you.
Thanks, guys. Well, that was great. I really enjoyed both Luke and Erva being here, and thought they brought a lot of value. And it was so interesting to hear about, Luke's take on infection prevention, all that they do. And boy, they've really had a rough road the last 18 months or so, and really learned to appreciate what they do every day.
I completely agree. It was fascinating talking to Luke, not only just like all the science and everything that goes into infection prevention and his role, but also how he seems to do a great job of keeping in mind that, patients aren't just a number. Like when he said that, there's a real human behind that. And what we do is ultimately not about just metrics and tracking things, but about saving people's lives. And I really appreciated his comments on that. And I really appreciated Erva's insight, just as someone who has had a role, obviously, that's been so important, has always been so important, but now with COVID, just the heightened awareness around EVS and how Erva's just and his team has responded to that and partnered with Luke and all the other, teams at their hospital. It was just really cool to hear, everything they're doing. And man, I just couldn't appreciate more the work that they do on the front lines and the things that they do to serve patients. I'm just super grateful for everything they're doing.
Yeah, thanks again, Erva and Luke. Really appreciate you guys joining us and bringing your expertise.
Yeah, I really appreciate everyone joining us for this conversation. I really hope that it was valuable and that you all gained some insight today.
Be sure to follow us and tune in for our next episode with another healthcare leader, wherever you listen to your podcasts. And for more tips in healthcare, follow the HHS blog at www.hhs1.com. See you next time.